I will share with you my clinical and research experience in terms of fat grafting for skin rejuvenation and skin improvement. So I'm from the Department of Plastic Surgery at the University of Lyon. I have no conflict of interest. Let's go direct to the point. So far, I can conclude, this is my conclusion actually, that fat grafting and stem cells, ASCs, adipose-derived stem cells, has different kind of effect on the skin. First one, that improves the quality in terms of dermal thickness, color, pore size, and I will present you a lot of cases about that. And secondly, it increases the healing process for ulcers, for chronic wounds, and it also serves, especially the adipose-derived stem cells, for tissue engineering, which is the future of regenerative medicine. And I will present our experience in this field. Everything is already published. You can find on PubMed. Regarding the skin improvement, it's been published in PRS and also in Sydney and Ricardo Mazzola book, and also the new edition will come out soon. So everything started in '98 after the first symposium in France, where Professor Magalon invited Sidney Coleman and he presented his technique. So immediately we started doing fat grafting using Coleman's technique, especially for volume restoration. So this young lady had an accident and with a ptosis, so we did for her application of the elevator muscle and fat grafting. And look at not only the volume, but keep in mind that we are focusing on the skin and the quality of the skin. And Norbert Paulo already presented cases that you cannot see the scar anymore. Look at this second patient, again in '98, 24 cc in each side. This is 16 months post-op. Look at the skin. Look at how the acne scar, not totally, but almost disappeared. This other patient had a Romberg syndrome. She had 3 procedures 16 months later. This other had a kind of atrophy of the malar area. She had 1 procedure, 7 cc's in each side. This other patient had a trauma with multiple scar in chin and lateral cheek. We did a facelift to restore also the contour of the neck, and with the combination of fat grafting at the same time that the facelift. You see the result. So we decided, and at this time I was doing my Master of Science, so we decided to go to the lab and to the animal lab and inject fat, exactly the same procedure that we are doing in the surgery, same centrifugation, same cannula, everything, and injecting fat in one side. And we had 3 different control groups on the other side. 10 mice without any procedure, 10 other we injected growth factors only, and 10 other that we just traumatized the sub-Q by tunneling with the cannula, because somebody can say that this is just an inflammation of the traumatism that you're creating under the skin. So 2 months later, we did a biopsy, and we took the opposite side as a control group. And look at the histology. So the control is on the left panel, and they're grafted on the right. You see these globules, these are fat, normal fat. And what was amazing at this time was that the quantity of the extracellular matrix. You see this brown, this is all collagen fibers. And we didn't know how come we had so much collagen fibers after fat grafting. So we decided to stain the cut with the anti-collagen 1 antibody. You know that the collagen 1 is the mature one, is the good one, and this is all the extracellular matrix was stained with this. So it means that in reaction to our fat grafting, the mice synthesize collagen 1. So it comes from the host, not from the donors, not from the human. So it means that our fat grafting is stimulating something within the subcutaneous layer. And we calculated the thickness of the dermis, and you see that the grafted side has almost twice the thickness of the dermis compared to the opposite side. So in conclusion of this study, we can say that fat is a bioactive filler, which will give you volume, but which will induce locally some change, some modification. That comes from signaling. Everything in human body is about signals, the crosstalk between cells, or sometimes a cell-cell interaction. But don't forget that mechanic, you know that we have on the sub-Q layer, we have all some mechanotransduction receptors. So when you put your fibroblast, whatever is the filler, it can be HA or other, as soon as you pull on your fibroblast, you transform fibroblast to myofibroblast, and your myofibroblast will synthesize collagen. So this is also one of the explanations of how, by just filling somewhere, you can improve the quality, because you will get more collagen. And this is something new. This is, I guess that Sydney hasn't seen this yet. This is something new we are doing in a research lab in Paris. So we are putting our cells in culture. Then we took what we call the secretome, the media, the signals which is in the media, and we put this in a fibroblast in culture. And you will see how fibroblasts are migrating with the signals coming from the adipose tissue. This is a wound model. So at the beginning, you have a scratch in the middle, you have fibroblasts in both sides, but you don't have any fibroblasts in the middle. You put just a drop of the media from adipocytes and from adipose-derived stem cells, and you see that fibroblasts are migrating. This is the chemotaxis to the middle part. That means that we have the signals which just appeal these fibroblasts to the center of the culture dish. So this is it's something that we are working on. So that you can understand that for this kind of patient, Romberg syndrome, we did only 1 session, how we can improve the quality of the derm and the quality of the skin, or for this other patient with the scar, with the forehead scar, she had multiple Z-plasty also, but during the same procedure of Z-plasties, I injected fat under the scar. Or this other patient with the morphia, with the sclerodermia of the forehead, we did this expanded advancement flap, then we injected 3 times fat. These are new indication of fat. But also for cosmetic procedures, and I have a talk on that on Saturday, you can really improve the quality of your facelift by doing the fat grafting procedure, and I think that now everybody is doing this kind of techniques. This is not something new. We will talk about on Saturday. These are results in cosmetic procedures. Immediate fat grafting with facelift. That was one of the old cases from my mentor, Jean-Louis Foyetier. You see this is 10 years ago, and this is 8 months after the surgery. It is amazing how the skin changed with the facelift for sure, but also with the improvement by adding fat. And look at this kind of inflammation. This is something very interesting. This patient with burn scars, we did she had just a piece of full thickness skin graft on the upper lip here, but no surgery on the neck. And you see how the inflammation decreased after fat grafting under this zone. And I will give you my thought about that later during this talk. So the second indication of fat grafting and stem cell therapy is the healing process. And this first study, we did it at the University of Southwest University with Spencer Brown and Rod Rorick. We irradiated the rats, the abdomen of rats, and we injected fat in one group. We supplemented the fat with ASCs in the second group, 1 million per cc, and then we had the control group. And we took a picture of the wound every 2 days, and we outlined the limit of the wound, and we calculated the healing process, which is the ulcerated area above the irradiated area. And we calculated for each rat the healing process, and then we did the average for each group of rats. And this is the final result of the study. If you look at the green curve, this is the control group. This is the normal way of healing. Everybody, every animal, every mammifer will heal. This is the speed of the healing process, the rat's healing process. And look at the yellow one. The yellow one is fat grafting alone, without supplementation of stem cells. And you can see that at between 15 to 25 days, we have an acceleration, an increase of the healing process. And this difference is significant. And it's the same than the supplemented group. You don't have, it's not faster when you put more stem cells, at least at the beginning. But if you look at after 65 days, the group with more stromal cells, more progenitor cells, it looks that we have a new increase. It needs at least 2 months or more to these progenitor cells to differentiate and to express themselves. So we switched to another study that was done in Lyon, and we took excisional wound, two pieces of skin on the back of the nude mice, immunodeficient, and we injected SVF. I'm sure that everybody knows. I will tell you later on. This is the stromal vascular fraction. This is the mixture of cells, not only stem cells. We injected cryopreserved stem cells, fresh stem cells, and we had 2 negative control groups. And we calculated the same thing, the healing process, and we did ultrasound Doppler after the healing was achieved, perfusion, and we did also biomechanical test of the scar. And you will see that's very interesting. Look at the healing index. The control group took more than 20 days to heal, almost 3 weeks to close the wound for these mice. But as soon as you inject ASCs, stem cells, you decrease about 1 week, about 3. It means that this difference is significant. The mice healed in 14 days only. And if you inject SVF, it's 16 days. This is also significant. It means that when you inject cells, you are for sure accelerating the healing process. And look at the histology. This is the non-treated wound on the left side. There is an inflammation, and this is normal for all healing process. We need inflammation to heal. But at some time, the inflammation must stop during the healing process. And look at the same time, at the same moment, the group who had fresh ASCs, there are no more inflammation. The scar looks mature. It looks like 3 months later, but it's exactly at the same time. And we calculated the inflammation score. And you see that the group with fresh ASCs has the best one. But cryopreserved also work. As Norbert said, you can cryopreserve these stromal cells and then use it later on for now we are using only for experimental models, but we can imagine that later we could use it for clinical. And look at these blood flow using ultrasound Doppler. You are increasing the blood flow around these wounds when you inject stem cells, and you are increasing much more when you inject the SVF, which is the total mixture. Perhaps because the SVF contains endothelial cells, all other kind of cells that it's not totally purified like the stem cells. So we have more blood flow around the wound. And regarding the mechanical test of the scar area, this is very interesting. This is what we call the Jung's model. It means that you are pressing the scar area, and you are calculating the time and the variation and the elasticity of this zone to came back to the normal position. And you compare this to the normal skin. And if you look at the control group, which is the right column, that is something that all doctors know. When you have a scar area, you are losing the elasticity of the skin, at least for several months. And this is that we found in the scar in the control group area. But in all other groups that we have injected cells, we are the same elasticity. We have the same elasticity than the normal skin. And this is something very interesting for our clinical applications. In terms of skin engineering, we are working in our lab in 2 different types. The one is the adipose skin equivalent, because so far we know how making the skin equivalent with epidermis and dermis, and how can we add hypodermis to it. And the second one is the endothelialized, which means that we are making new blood vessels within our skin equivalent. So this is the model using collagen, glycoaminoglycan, and chitosan scaffold. We are injecting stem cells at day 0. Then at day 7, we add fibroblasts. So we are doing a co-culture of these 2 cells in immersion for 1 month, 28 days, in order to seed these cells evenly within the scaffold. And then at day 28, we add keratinocytes on top for 7 days, and we leave it in an interface air liquid. Why? Because of different strats of the epidermis. So we will get this kind of model. And this is small pieces that we are able to recreate so far. Look at the histology. That contains hypodermis. For sure, these are very small pieces, so there is no clinical application so far. But it means that in future, we could probably, for burn patient or other indication, give better culture than we are doing now. And this is the histology with the oil redo. And this other model is exactly the same model, but instead of injecting the stem cells, we pre-differentiated the stem cells to endothelial cells pathway. This is very important. This is a key word, because these cells, you have to give them the right signal to differentiate. So we give them the signal before the culture to the endothelial cell, and then we add it within the same model. And this is the normal histology. And look at the immunofluorescence characterization. We are in the group who had pre-differentiated ASCs. We have this kind of tubular structure that will give later some new vessels within our skin equivalent model. So it means that this is also a new way of research we can implement, and we can improve the quality of our skin models. So to conclude about these studies, we can say so far that you can use fat grafting only for volume if you want, large volume, small volume, whatever is the indication, or for regenerative cell effects, or for both. So these are different things. And for regenerative effect, we need anti-inflammatory effect, or sometimes to push the healing process. And I will tell you that this is the fat tissue. So you have adipocytes, and you have the SVF, the stromal vascular fraction, which contains the stem cells. If you want the stem cells, that has to be clear for everyone. You have to go through this normal centrifugation, then keep the fat, only the middle part, then use collagenase. This is an enzyme which will digest the whole collagen fibers. Then you centrifuge again, and the SVF is this pellet. It's a very small quantity, but high number of cells. This is the SVF. It took about 1 hour to get there. Then if you want stem cells, you have to pellet this SVF in culture. So you need a research lab so far. And that took at least 24 to 48 hours, at least, in order to select one type of cells. These are signals from stem cells and from adipocytes. I think that we are not talking enough about adipocytes, the mature cells. Because regarding Kotaro Yoshimura, when you do your fat grafting, all mature cells dies. Perhaps, I have no idea about that. But during this time of oxidative stress, these cells will secrete a lot of signals. And this is a study done at the University of Lyon from one of my colleagues. He sent me this. Actually, we know that adipocytes, we all learn at the university that we have small adipocytes, large adipocytes, and when you increase the weight, with our small adipocytes increasing in size, and we get large adipocytes. This is not true. We have two subpopulations of adipocytes. We have the small one, the large one, and these are different cells. The large one can get larger, but the small one cannot get large. And regarding his studies, the small one gives anti-inflammatory signals, while the large one gives pro-inflammatory. That's why if you look at obese patients where you do surgery, this fat gives a lot of oil, and the oil gives a lot of inflammation when you inject this fat. This is not a good fat. And regarding his study, I try to understand, can we select the size of these cells regarding the indication we want? So can we select with these kind of small cannulas, the micro, the medium, the large, the size of adipocytes? And I sent to this guy some samples of my fat harvested with like micro cannulas with 0.6 millimeter of holes. And for sure you can get more small cells, but with the large one you have a mixture of all. It's not only large cells. You know what I mean? It's not totally selective, but when you use small cannula, micro cannula, you have more small cells. So it could be, if you need some anti-inflammatory fat in filler, you should probably use smaller cannula. That is the idea behind this. And in a study that we have done, when you inject your cells without scaffold, look at this. This is mature adipocytes or culture ASC, stem cells. When you don't use any scaffold, you are using everything. You are losing everything. So why? Because when you inject your cells in the body, it needs to be gathered with a three-dimensional environment. So in a bioengineering model, the first and the most important part is the scaffold. Then you put inside your progenitor cells, then the microenvironment will work for you or against you. So in scaffold, we have fat, which can serve as a scaffold for more cells. You can use HA or you can use now PRP. And this is the model of Kotaro, the cell-assisted lipotransfer, which means that you put more cells within your fat. And this is one way to use fat as a scaffold. Then if you want to use a hyaluronic acid, we did a study, and that's just been published in G-Press. If you use the cross-linked hyaluronic acid in the market, it doesn't work. I have heard in some symposium that you can mix your cells with hyaluronic acid. No. If you put your cells within a cross-linked hyaluronic acid, these cells will die because the oxygen cannot get inside to regenerate these cells. So we have found, you're looking on the market, we have found a non-cross-linked hyaluronic acid, which gives us actually best activity. This is the MTT, this is the viability of cells that are control media. And I have injected cells within this new media, which is a non-cross-linked hyaluronic acid, and 50 other components with amino acids, vitamins, everything, and we are able to recreate some fat tissue with an injectable collagen, with an injectable non-cross-linked scaffold. So I will just finish by presenting you this movie. It takes like 4 minutes, just to show you that what we are able to do so far. This is PRP preparation. So you harvest blood before injecting lidocaine to your patient if it's a local surgery. So this is the PRP already prepared. And I don't know if you observed, that was two different parts, the poor plasma and the rich plasma. Then we harvested fat, we centrifuge fat. I still centrifuge fat for facial surgery. And so this is the fat after centrifugation. You discard the bottom, the tumescent, and then we are mixing, as Norbert said, we are mixing fat with PRP. That gives more growth factor, that increases the take. Then I harvest again fat. This is just to show you that now in 2015, we can do a lot of things. This is after mixture, like Patrick Tonard, multiple passages, emulsification of the cells. Then I centrifuge for it twice. This is the second centrifuge of the emulsified fat. And look at here, you have the oil, you have the fat, which will serve as a matrix. Then in the tumescent part, there are some pellets, because I mechanically destroyed a little bit my fat. But I wanted to do that because of the cells that I will get in the pellet. This is not the fat that I will inject. So these cells, I will mix it with PRP. PRP will serve as a scaffold in this case. So this is just to show you that fat can be a scaffold, PRP can be a scaffold. You can supplement your fat with PRP. You can supplement your fat with some more cells. These are all options that we have now, and you have to adapt your technique to your indication. What are you looking for? So this is the mixture, it's very slowly with the PRP. So we have here 3 different products, nanofat, SVF, and PRP, and fat and PRP and supplementation. And you will see that I will put some fat, plain fat, in deep layer to get volume. Then I will change my way to inject. I will do multiple passages more superficially. I will also inject wrinkles using small cannula or sometimes a sharp needle if you want to be within the dermis. So these are all new tricks that you can use all together to improve the quality and of your outcome, of your clinical outcome. So you need a plan when you do your surgery. I always say, like, listen, I need 10 cc's of plain fat, then I need 2 cc's of emulsified, and I need 4 cc's of PRP. So I make a plan, and I use different kind of products for different indications for different zones. So I have injected the face, then I will use the enriched one with PRP more superficially, just to improve the quality of skin. And you see that I'm not using the same technique, I'm using more multiple tunnels that when I want to do just the volume. And On top of that, I will inject separately the PRP alone, just in the dermis like a mesotherapy for the healing process, because it decreased the inflammation, it decreased the bruising, and also it improved the quality of the skin. And this is a very difficult area that I usually treat from the central part. And now I am using emulsified fat, dilute fat, but I'm injecting more superficially than only just in contact of the bone. And I also inject PRP in this area to increase the thickness of the lower eyelid skin. You see, these are very small droplets of liquid fat. Your fat has to contain small cells, small lobules, and a little bit of liquid in order to spread evenly and easily. And the intradermis injection using a needle, be careful also when you do that, in order to not to be in a blood vessel. So that was just to show you different product and different techniques. This is the plain PRP that you can activate or not. This is another question. You see, this is just under the eyelid skin. All these procedures take about 1 hour, 1 to 1.5 hours, not more, because they are not collagenase treatment, which is not allowed in Europe. This is an example of fat grafting with all these techniques, without any other procedure, no facelift, and you see how you can improve the quality of the skin, you can improve the volume, you can inject the lower eyelid, the upper eyelid, and all other parts that we will talk about on Saturday. Thank you for your attention.